Okay.
Yes, sir. Certain, sir.
Okay, very good evening, friends. We are talking about today about the most important topic for us, because this is the topic. This is the information that we are least bothered about in our practice and regarding our health and our profession is concerned. And health hazards for an anesthetist is a myth or reality. Somebody says it is a myth. Somebody says it's a reality. And what is true? We are going to discuss about it today. Why we have to know about these hazards? Because the motivation for this class to take is Dr. Raja, who has somewhat elaborated in the night of our campfire. He started to give some of the points regarding our hazards, what we have faced day-to-day practice. And after that time, I want to take about the detailed class and the health hazards for our anesthetist. Am I audible now? I'm audible? I'm audible now? Hello?
Yes, sir. Yes, sir.
Okay, okay. So, and there is a need of the hour today because we are in a position compared with other specialty, we are in a high occupational hazard. We are facing this high occupational hazard compared to other specialties are concerned, because we are in a safety oriented specialty. We give more safety than our practice. Safety first and practice next. That is our motto of this, our practice. And Doctor's life called Harshini, who said that the qualities you need to get through medical school and residency, that is discipline, patience, and perseverance. The 3-1. That is, we are willing to forgo sleep and ability to weather crisis of faith and self-confidence, accept exhaustion as a fact of life. That is a real pathetic situation of our doctors. An addiction to caffeine is a definite plus because of the added hours of practice. An unfailing optimism, that is the end in this sight. He is an famous novelist called Hosni and formerly a physician, and he mused about the doctor's life in this above mentioned quote. Okay, anesthesiologists are not different breed of physicians. Their entire strenuous life pattern, work in inhuman hours, or at a massive amount of stress that should be best at their work and patient lives or in their hands. Okay. So the lifestyle, the anesthesia is compared with the aviation industry. Aviation means the flight and what our pilot is doing. The same thing we are doing here. Because the parallels are drawn in anesthesia with the aviation industry ensure safety and minimize the risk. We are dealing with anesthesia workstations, anesthesia plans, and optimization of the medical condition and preparation of the patient, equipments, drugs, and team are all meticulously verified before we starting a case. The same thing, every aspect in flight when you take off, and everything will be checked thoroughly before taking into an operation. The same thing that is parallelly drawn as an anesthesia. Though anesthesia and aviation industry are almost same in executing the safety practices. That is the scope of anesthesiology has now widened today. We are not only in operation theater, we are also in ICUs, we are in labor rooms, we are in emergency department, and trauma and disaster situations, and resuscitation rooms, pain clinics, outpatient consultation, anesthesia outside the operation theaters. That is called anesthesia and remote locations. These are all the areas we are extended our specialty. We are going to subspecialty also. So the scope of anesthesia has now broadened so far else that the literature regarding our safety features, the hazards to the anesthetist, the literatures are very, very low. The literature is full of articles other than this, all our matters regarding our subject and ICUs, but much focus on the risk to the anesthetic receiver and the patient, but the health hazards of the anesthesiologist who delivered anesthesia faces are scarcely published. That is a very pathetic situation by the literature. So there is a need of the hour to know about what are the hazards we are facing day-to-day life. Going to the history, our pioneers, Horace Wells, we know about it. Horace Wells is the man first who used nitrous oxide for dental anesthesia. But what happens to the Horace Wells? So the hazards to the anesthetist starts from this onwards, from 1800s onwards. And Horace Wells suffered from severe depression, addiction, and finally he committed suicide. So he is the first anesthetist who committed suicide because of the stress, burnout. This is the history says. And next, W.T.G. Morton, who is our anesthesia father, our father of anesthesia, who convinced the world for giving anesthesia by ether anesthesia. We are going to celebrate on the coming 16th of October. But during his turnover, he has not completed his medical career. That is a very pathetic situation because of the stress in his life in W.T.G. Morton. And during his throughout life, he is not at all recognized as the credit of ether anesthesia during his life. Only after his death only, he has recognized that is the credit for the ether anesthesia. That is the situation of our pioneers in history. So the addiction, depression, committing suicide is all inevitable for our specialty is concerned. And later long-term effects, that is by our inhalation agents and lack of scavenging systems and gas analyzers, that is not possible in developing countries. And we are more prone for bloodborne infections and drug abuse and work-related stress and burnouts. These are all the common long-term effects that are all offered by our specialty that we have chosen. We have to pay for the penalty for the specialty that we have chosen. It's a very sad set of affairs. What are the challenges we have to face? We are unending work shifts and we are running in a stress-ridden environment that is inevitable because of our specialty, and pressure to accommodate more cases contribute to hospital productivity. We should not be able to deny the cases. We have to add more and more and more. We cannot be able to deny because of the hospital productivity. You have to give the census because of the authority. If you reject the case, you have to explain so many persons of our higher officials. And exposure to multiple health, safety, and performance hazards are not inevitable. So, because with these effects, our health is somewhat jeopardized. What do you mean by health? As per the definition of health, by WHO definition, it is not only mere a physical one. It is a physical well-being, mental well-being, spiritual well-being, and social well-being. All the four should be present to come to the definition of health. But we are all not. We are not weighing these four aspects in a very good way, in a very balanced way. There is a very sad situation. They are least bothered about our physical and mental and spiritual and social well-being. We are giving less time for all those areas is concerned. And what are the physical hazards we are facing? We are more prone for waste gas exposure. And we are more prone for radiation exposure. And we are more prone for allergies and infection by inoculation. And very poor pregnancy outcomes in ladies of the anesthetist is concerned. These are all the physical hazards. We'll go into the detail one by one later. And then mental hazards, what are all the things that we are facing now? Is stress and burnout. It is inevitable. That is a very sorry situation for the anesthetist. And substance abuse because of the stress and burnout. That is very common in anesthetists. And ambience related stress, what are the environments that will cause the stress? We will all discuss in later. This is our overall view about it. And other hazards that we can have this impairment and disability as the age grows. And there are so many studies shows that anesthetists will become disabled person as the age grows. And we are more stressed about the malpractice claims and violence faced by the patient relatives and fires and accidents. It is inevitable also inside the operating rooms. These are all the other hazards. Now you can go to the waste gas exposure. We are using the volatile agents that are all nitrous oxide, halothane, isoflurane, desflurane, and ceoflurane. In the working environment, the anesthetics have been known to induce. These are all the agents that will cause carcinogenesis, mutagenesis, and hepatotoxicity. These are all the studies such that the animal model studies shows that these are all the agents causing these type of hazards to us. There are some of the, we are all subchronic and chronic exposure of these waste gases that lead on to so many problems, especially in CNS problems. We are having headaches commonly, dizziness, fatigue, and memory loss. This memory loss is very common to our anesthetists because of this. We are subanesthetic dose of these volatile agents, or we are all inhaled, that lead on to memory loss. There is memory loss. The cognitive dysfunction is very common in anesthetist. And regarding liver is concerned, we are not using this halothane now. Very good. But in those days, in our days, in my PG days, we are using only halothane. That is the only agent that is available in our time. That will cause some halothane hepatitis, and that cause, or otherwise call it cause elevated liver enzymes and massive hepatic cell necrosis. These are all the case reports are there. And these are all some genetic effects. It will produce this chronic exposure of these volatile agents that will produce chromatin changes and chromosomal aberrations, and micronuclear degenerations may occur. And these NIOSH, that is National Institute of Occupational Safety and Health, has some of the recommendations. What are the things that you have to do? And the REL, that is recommended exposure limit, what is there? That we are all, these are recommendations. You can, I don't want to go into the details of this. You can go to the net and surf it, and this REL and NIOSH 1977. If you type it, that will give you the recommendations of this. They are enormous. The recommendations are so much enormous. But the only happy thing is, but there is no animal or human studies has proved, but studies are there, but not at all fully proved by conclusive evidence of direct organ toxicity of halogenated anesthetics. If the exposure is in low concentration for chronic period of time. So what we have to do, we have to minimize this exposure by air circulation in the OT, and suctioning and scavenging systems, and low flow rates, cuffed endotracheal tubes. These are all our systems that will minimize our exposure to the gases, to the ideal agents. And radiation exposure. And radiation exposure, regarding this, anesthetists are all more prone for this radiation exposure because we are giving workplaces at CT scans, computer tomography, MRI suits, and PET scans, and cath labs and fluoroscopy rooms. So the ionizing radiation affects organs that are most susceptible to, which are the organs that are all most affected? The gonads, the bone marrow, thyroid, lung, colon, eyes, and stomach. So what is the maximum radiation exposure that can be done per year? That is very low. That is annual exposure that should be 20 millisievert units. That is 1 millisievert unit is called, we are exposing to 100 X-rays, 100 shots of X-rays. So that should be 20 per year annual. That will be maximum up to 50 millisieverts exposures. That is the maximum exposure by our radiation. For that is the annual exposure limit per year. For that, what we have to do, what is the recommendation says that we should apply dosimeter in the forehead that calculates how much amount of radiation that is exposed to you. That will show you. And by this, and this exposure depends on these following factors. That is, by the duration of the exposure and distance from the source of radiation scattering. And we have to utilize these lead seals, very important. And we are least bothered about the eyes because we always take these goggles during our exposure, that is eye wear. These are all the recommendations by our NIOS. So the duration of the exposure and distance from the source and lead seals and eye wear all will protect you from this radiation exposure. Because we started. And next one is the allergies. What are the agents that will cause allergies is choline and latex products, the gloves, whatever the materials. The rubber materials used should be latex free. These are all latex products. And opioids, colloids, and iodine compounds and radioactive materials and antibiotics. These are all the agents used in our anesthesia practice that will cause allergies. The most common is the latex allergy. The latex allergy mostly usually in the form of gloves, but they're using this face mask, gloves, any tubings, catheters, drains, and rubber stoppers for the vials and equipments. All are the agents that is the source of our latex allergy. And latex allergy is only recognized entity in hospitals. The effect of latex allergy is they are having immuno effects. That is by this mediated by T cells like irritant contact dermatitis will cause. That is present with this delayed type 4 sensitivity. Sometimes this latex allergy is very dangerous. It will cause anaphylactic shock also by IgE release. So the dermatitis is often exacerbated in the operations that occur by use of strong soaps sometimes. So compulsory frequent hand washing because sometimes good also, the same time it will cause bad also. By this drying effect will cause dermatitis also. So it will cause and in the inhalation agents and the powders in the gloves that will cause conjunctivitis, rhinitis, bronchitis, and it will cause serious effect also sometimes. That is, it will cause form of tachycardia, hypotension, chest pains. Sometimes these powders may cause anaphylactic shock also, cardiovascular collapse. The cases are reported in allergic individuals, IgE, allergic persons who are an anaesthetist of allergic individuals exposed to the powders. It will cause anaphylactic shock also. The case reports, the journals are available. And it will produce gastrointestinal side effects like crampy abdominal pains, chronic diarrhea due to allergy to certain irritants in the OT can be misdiagnosed as infection, stress-related, sometimes inflammatory bowel disease. So the need of the hour is you should use for the following days, you should use the power-free, latex-free gloves that are all available but somewhat costly. And if possible, you can use PPE kits for your safety. And housekeeping, frequent housekeeping, and vacuuming our theaters. It is very essential for this hour. We can be less exposed to our irritants of this low dose of inhalation agents and powders present in the operation theater environments. And you can use the very mild level of soaps. Otherwise, it will cause irritant dermatitis because of the drying effect of our skin. So these are all the areas that we should have to concern about it. Okay. And infection, we are inviting infection because it is inevitable. The most common is hepatitis B and C and HIV. And next one is the airborne pathogens like tuberculosis and contact infections by staph aureus. That is called methicillin resistant staph aureus infections are very common. And we can have the sore throat very commonly when we are contracting this staph aureus infection in ICU rounds and in operation theater of closed environment. And next, most important is self-inoculation by needles, needle pricking, especially by resheathing the needles. It should not be done. That is, that we have to follow our norms, universal precautions. So the awareness about this infection is you have to follow the universal precautions using these double gloves, PPEs, goggles, all those things. You should be vaccinated about hepatitis B, and any vaccines available, you should be anaesthetist should have to take it in early. And the waste management protocols in the theater for regarding the cleanness of the theater, that will cause this biological waste in the theater will cause source of infection. And screening of the blood and blood products and tissues for viral markers have substantially reduced the incidence of knee infections. You should be aware about it also, most important thing. And regarding the ladies is concerned, pregnancy, poor pregnancy outcomes, and we are all more prone for the spontaneous abortions, preterm deliveries, and congenital malformation and low birth weight babies, IUGR. These are all the case reports are there. And mental. What do you mean by stress and burnouts are inevitable for anesthetists? I already told earlier. What do you mean by this word stress? It is a non-specific response to your body to adapt any change or demand or pressure, situation or a challenge. So it is a non-specific response of a body to adapt any change or demand or pressure, situation or challenge. It involves physical, psychological, and behavioral ramifications in response to real or perceived threat or trauma. That is called stress. So, what are all the situations that will cause stress? Who are all the stressors for our in our practice? If you take ASA 3 and 4 case, the adrenaline will be pumped out into the circulation. If you are dealing with a difficult airway and irregular working hours and complex and intra-departmental interactions, quarreling with our interdepartmental and intra-departmental regarding the case or failures, and unhealthy food and lifestyle, you are taking in practice in hard hours, taking paratha and chicken in night 12 o'clock, and unanticipated mishaps, anesthetic accidents happens in the OT, and medical legal consequences because of our anesthetic accidents happened, the legal issues. So these are all the stressors for our anesthetists. You should be very careful. And the burnouts, almost the neurotic individuals are more prone for these burnouts, and including different work profiles, even not only the anesthetists, the nurses, consultants and directors in higher positions also having these burnouts, and the prevalence is very high, 10 to 59% because of the strained work pattern. And the end position of the consultants having your and spending less time with your kids, all cause burnouts, family burnouts. And we're all, because of the burnouts, where the most anesthetists are using abuse, substance abuse, very common in anesthesiologists. There is CRNA, not only the anesthetist, there is a certified registered nurse anesthetist. This is the terminology in US. They are most important person. They are helping hands to the anesthetist. That is CRNA, certified registered nurse anesthetist. They are, according to their studies, the greatest risk population were young male CRNAs and anesthetists. What are the drugs that are commonly misused, abused? One is the benzodiazepines, most common is diazepam or midazolam. And opioids, most common pethidine or fentanyl, sufentanil. And next one is the ketamine. Ketamine addiction is very common in anesthesiologists. I know My friend and my PG days will become ketamine addict. So these are all the drugs for abuse. And what are the signs of the drug abuse? Can you able to judge about it? Yes. There is any outburst of anger very frequently and impaired job quality and poor interpersonal relationship and mood swings and reduced or exaggerated libido. They will cause so many mishappenings inside the operation theater because of the reduced or exaggerated libido. They are very common in OT corridors and OT complex. It is very common. And ambience related stress, because we are doing this inside the operation theater or alarm or ICUs, the beeps and alarms and bells and screeching and clanking metal trolleys and instruments and false alarm bells, along with low lighting, poor ventilation. This is a composition of the anesthesia workplace. This is where we are working there. That is our ambience. That is our environment of our workplace. It will cause alarm fatigue. There is a new terminology that is called alarm fatigue. It's a new reality. There's a false alarm bells distract the clinicians and exhaust his patients. Instead of helping him, and this hinder the care towards the patient. And FDA has recommended, the study shows that 566 persons death reports due to alarm caused by monitoring the device between the years 2005 to 2010. The need of the hour is to reduce the burden of noise pollution. That is most important on patients, and reduce the number of false alarms is worth investing in. So for that, we have to use this noise pollution, reducing the noise pollution by means of AI, that is called artificial intelligence. They are using this now. That is going on now. Artificial intelligence is going on. That will reduce our noise pollution. It will cut off unnecessary alarms and to reduce the work stress of the anesthesiologist and the team of the anesthesiologist is concerned. And impairment and disability, because the anesthesiologists are vulnerable set of physicians when slightest impairment, physical, psychological, intellectual, behavioral, spiritual, or social may affect their work and skills. And mostly 50% anesthesiologists will have in the backache because the backache shows that they is stressed. And the anesthetists are more prone for musculoskeletal injuries, driving two-wheelers or four-wheelers in the odd hours. And the study shows that the anesthetists are more prone for hearing impairment because of the irrelevant alarms and the stress work pattern. And the study shows that abdominal audiograms are very common in anesthesiologists. A study demonstrated almost 66% of anesthesiologists have abdominal audiograms, especially at high frequency. Abdominal loudness perception, tinnitus, difficulty with localizing the sounds, and other problems are affecting the anesthesiologist. These are the study by Canadian anesthesiologist survey. Shows that these type of problems. And old age may not be considered as a disability, but elderly anesthesiologists may find it difficult to function in the night shifts and for longer working hours. So these anesthesiologists are more prone for substance abuse disorders also. And cognitive impairment is very common. That is due to age or any other cause like Alzheimer's disease. And 2013 survey, Canadian survey found that among the Canadian anesthesiologists, 22% were at the age group of 55 to 64 years having this cognitive dysfunction, and 7% at the age group of 65 to 74 years, and 3% were older than 74 years. So cognitive dysfunction is common as age advances for the anesthesiologist concerned, very pathetic situation. So the study concluded that the adverse patient events had an association with elderly anesthesiologists, and younger and middle-aged anesthesiologists are scored better in this regard. And next one is the malpractice claims. That is very cumbersome. There is an unpleasant experience being held liable by a patient who suffered a major or minor outcome, adverse outcome. That incidence is 2%. There is an unpleasant experience. And the verdict has been given in favor of plaintiff, but win or lose, a defendant anesthesiologist being sued loses of valuable time and can suffer immense loss of reputation of his professionalism. Very pathetic situation. The survey showed that the anesthesiologist spent about 40 hours preparing for trial and up to 50 hours in the court, and for 1 to 3 years or even more in changing patterns of surgeries in favor of day case that lead to more case of lawsuits on outpatient procedures. But the amount of settlements and awards have slowed down this practice. So the amount of settlements by the court of law, by the medical legal aspect is very, very high. That produce so much of stress and burnouts in our anesthesia professionalism. And violence, it is also common in ICUs and OT because of the death of the very sick patients. The team is most vulnerable for physical abuse beaten by the attenders of the patient. And the survey, 2003 survey in ICUs in England and Wales interviewed nurses and doctors about their unpleasant encounters with the patient and the relatives for at least in 12 months, found that violent behavior is very commonplace in these places, especially with the physical abuse, very pathetic situation. And inside the OT, you can get this violence by this emergence delirium by the patient, and the patient is coming out of the general anesthesia by using this ketamine or any other inhalation agents, especially in fluorine. And it will cause what problems that will occur in emergence delirium in the patient we are dealing with inside the OT. And the patients are so much violent and trash the anesthesia and forcefully pull out the wires, lines and catheters, causing self-injury, risk of falling from the OT table and injuring themselves. So some may even extubate themselves. Self-extubation is very common. These patients not only harm the operating room workers, but also themselves. Various factors have been identified in precipitation of this delirium, including benzodiazepines preoperatively we are using, and long duration of the surgeries, breast surgeries and common surgeries, and volatile agents used, and the use of ketamine. All those are agents more prone for this emergence delirium that will cause so much of nuisance for the anesthetist, both physically and mentally. And fires and accidents are not uncommon. They will happen because we are working in an oxygen enriched atmosphere with nitrous oxide, which is highly inflammable. Okay. And the report says that 1 to 10%. And overall report says that by this fire and safety, FDA reports says that there are minimum of 100 to 200 fires in the operating rooms are reported. And serious patient harm has been reported to 20%. And the patient deaths are reported very rarely and are second to airway fire when you are using this airway fire accident, when you are using this laser anesthesia, in especially in airway surgeries. The fire of the airway is very common. So, come to this conclusion, we are talking about the so much of negative aspects. We have to deal about the safety practices that is most important. So, the occupational hazards by the anesthesiology are not, reality not a myth. The extent of the exposure of the risk can be markedly reduced. And we have to strict adherence to our safety practices. So professional liability and insurance scheme, you have to take care of it. And our ISA has now come to implement this cover you plan Everybody should have to get the insurance policy to safeguard your skin first, then patient. And you should be very careful about this availability of safety equipment, if it is available in the theater or not. Before starting up the case, don't never compromise any equipments. And reducing the odd hour practice, the late midnights, the tired, when you are so much tired, accepting the case, unless otherwise it is a dire emergency. That is the most important. The safety practice is most important. Otherwise, because in those times you are liable to do mistakes, because we are alone, our brain is not alert at those times. Okay, be careful. And using closed circulation scavenging system, you have to opt for it. Then only we can have a very reducing or cutting off the exposure of the wastage of anesthetic gases. And proper air exchanges inside the theater and environmental control of the OT is most important for our safety, health safety. We should be make sure about it. And then dosimeters, which I told earlier, you have to apply in your forehead when you are exposed to radiation exposed environment. That will tell you how much you are exposed to radiation exposure you have done for that day. And we can calculate how much you are exposed to annually. So the maximum is 50 sievert units. That is, 1 sievert unit is equal to 100 into roentgen exposure. That is 100 X-rays. And we never bother about the money. It should be used this latex-free products. You can safeguard your skin and allergies, sometimes anaphylaxis. And we are touching the gloves and any materials regarding latex. Hand washing after contact with the latex products is most important thing. Otherwise, this will produce delayed hypersensitivity reaction, produce chronic dermatitis and eczema in your body. And keep always universal precautions, because we are the most notorious person will contract the infection inside the operation theater by needle inoculations. So adding using goggles, PPE, and double gloves, never resheath the needles. Okay. And then alarm fatigue is very common. Should you have to use this, go to the advancements of it to include artificial intelligence in the alarms. Unnecessary false alarms to be stopped. It will produce noise pollution and lead on to stress also. So stress-free practice, always be planned for it. It is most important, because alarm fatigue, noise effects, hearing disability, backaches are due to repeated manual handling of patients and or recognized hazards. So the conclusion, my dear colleagues and my dear students, recognize the occupational hazards and quality measures and quality measures to be reduced. Quality measures to be implemented to reduce our hazards and manage the risks. That is my information today. I thank Dr. Raja for this. He inspired me to take the class, and these were all the hazards we have faced in our profession. And this is the penalty we have to pay for it. There is no other go. So by recognizing this occupational hazards of choosing this specialty, we should definitely have to do measures to implement to reduce it.